Good morning.
Good morning.
That's the sign. May the force be with you. Anyway, I've got questions and I'm going to go ahead and just get started quickly. Number one, good morning. Dr. Rosensweet, do we know if testosterone or estriol will convert to estradiol? I hear that estradiol needs to reach a good level in the body, as in 150 or more. Is this true? Saying to say that if we have to get our estriol up, will this give us the long-term benefits of avoiding premature dementia? I'm wondering if 50-50 biased will accomplish this. If so, estradiol, 50 milligrams of estradiol and 80 of estriol, is that too much? Thank you so much. So there are like 3 questions in there, but I think you got it.
50 and 80, that doesn't add up.
How it was written.
Near the end, I'd like to hear more about that, but good question. I mean, the general topic is estrogen, and does estrogen matter? Holy mackerel, estrogen matters. These are some of the most powerful biochemicals in our body. And the woman's ovaries produces 4 of them, and estrogen family is one of them. And estrogen receptor sites are everywhere. You know, we tend to think of estrogen as related to the uterus, female functions, menstruations, and the breasts, preparation for lactation. But they're everywhere. There's just an enormous number of estriol. That's one of the 3 major estrogens, receptor sites in the brain. There's estrogen receptors in the bone. That means if there's not enough estrogen stimulation of bones, you lose bone. It's not a question. It's not a risk. It's going to happen. Just, you're going to lose bone. I don't know that there's any exceptions to that. That relates to estrogen's effect on bone, and estrogen is crucial to the coronary arteries. Estrogen really matters all over the place. I'm just giving the audience an introduction to this, and you know this one. And then replenishing estrogen when a woman starts losing her hormones, and by a couple years into menopause, a woman has 1% of the estrogen that she had when she was young. The technical scientific term for that is Oigavalt.
Can you spell it?
And but the replenishing of estrogen in this day and age is so elegant, so terrific, so many possibilities, and including the possibility of doing it right and doing it excellent. Yes, testosterone does convert to estradiol. And it's one minimal but insufficient way that a woman can adjust to menopause and not lose all of her estrogen.
Yeah.
And because testosterone is coming out of the ovary, primarily in a young woman, a young woman has as much testosterone as she has the most potent estrogen, estradiol. Testosterone, as I've said many times, is not a male hormone. It's a human hormone. It's crucial for women and crucial to get it right. Well, so are the others. So, I don't want to single it out. And yet there's some testosterone and DHEA coming out of the adrenal glands. So when a woman's ovary shuts down, there is the opportunity to get some testosterone. And where does testosterone get converted? In the fat cells of the body. Women who don't have much fat don't do much conversion. Women who have a lot of fat cells do conversion, but not enough to bring the period back, and probably not enough to do enough good. The levels aren't high enough. We know the amount of estrogen that a woman needs, bottom line. Scientific studies have shown us that a woman needs a certain amount of estrogen levels, not menopausal, a certain amount of estrogen levels to protect, for example, her bones and her vagina. Studies have been done. We know the numbers. And these aren't the levels needed to menstruate, but they fall just below it. Like if women vary a lot according to how much estrogen they need. Some women are really rich and robust in estrogen, and they have levels when they're young up here. Some women don't need that much. They're functioning on what would consider relatively a minimum amount. But every woman within this spectrum can be healthy, regularly menstruate, get pregnant, have normal female function. Somewhere in this range. You can't. It varies. We're individuals. There's individual variation. In fact, this number can be 3 times what this number is. That's how much variation there is. Menopause treatment at least must begin here, right below what it takes to menstruate, which means you don't have to restore the menstrual period. There is an exception to this, but you don't even want to restore the menstrual period. That's going to stimulate breast glandular cells to proliferate if you get up to those levels. So we don't consider that to be desirable or necessary, although there are a few exceptions. Some women, you really have to run the estrogen up to restore their brain, their cognitive function. And I've spoken about that, and I can speak about it again. Now, what is the level? Blood tests? I'm just not a fan of blood tests because of, when did you take your last dose? What is that 150 based on? Is there a real steady state there that assessing the blood can really assess what's going on in the estrogen levels of a woman? And in my opinion, no, it's unsatisfactory for that. Though a lot of physicians function quite well with blood tests, especially if they get the timing down and standardized between when the woman took her last dose. But all of that is cured by doing the 24-hour urine hormone test. I'm not talking about other urine hormone tests. I'm not talking about the urinary 5-point test, urinating onto filter paper. I'm not talking about that. I'm talking about collecting urine for 24 hours. There's 3 laboratories in the United States that do it. At this very moment, those 3 laboratories are sitting with my urine. I collected for 24 hours and I split it up between 3 laboratories because every so often I like to see how the laboratories are doing. And I also sent a sample off to the 5-point. So I have some interesting things to report here in a couple of weeks when the results come in. How well the labs stack up against one another. And that takes care of, doesn't matter when you take your hormones, just so long as you take them regularly, every day running up to the collection of urine, and during the 24 hours you're collecting the urine, it doesn't matter when you took your last dose because you're dealing with a full 24-hour sampling. It's the gold standard. I've gone into this many times. Hello there, kitty cat.
I know, he's gonna, guess what? Okay, we got him. Okay, he's happy now. He's in his 6th place.
So I went into the medical literature and I extrapolated the data of what's enough estrogen. And we know what that is for the 24-hour urine hormone test. A woman needs to, when you add up the potent estrogens, estradiol plus estrone, you want that to add up to at least 8 micrograms per 24 hours. And it should go up, the optimal range is between 8 and 14 with exceptions. So we know that, and we do 24-hour urines on 100% of our patients. We wait until they've, usually somewhere between the 3 and 5 month mark when they've dialed in their optimal dosages, and that's how much you need. And when you do the 24-hour urine test, you get to identify it with accuracy. Now, there's a lot of other measures. We don't just rely on hormone testing. How much is enough estrogen? Well, the woman has to have enough to protect her bones, and we can assess bones through bone mineral density or a blood or urine test that samples the amount of bone breakdown products, because bone is constantly breaking down and rebuilding constantly. your whole life. There's a certain normal amount of bone breakdown products in the urine. And if it gets too high, what does that tell us? That bone's breaking down too fast. And then we go investigate why that's so. And in our book, Happy Healthy Hormones, we have a whole chapter on bones. So if you want to learn more about how to protect your bones, well, take estrogen, one thing,
Yeah.
and use progesterone and use testosterone. That's going to protect your bones. You need them all. Thyroid
Well,
too.
so if your bones were not so great at the beginning of year 7, and you're taking testosterone and Biased and DHEA and testosterone, would you think to say that it would be likely that your bones would get better at that 7-year mark?
The 7-year mark. I'm
Of
not
bones changing.
sure how you're
You know.
using that, the 7-year mark.
Well, you
Uh,
said bones like change every 7 years, pretty
well,
much.
they're changing all the time, every microsecond. They have an active metabolic process going on, and what that process involves is there's cells that break old bone down, and there's other cells that create new bone in place of the old bone, and that's taking place every microsecond. The 7-year thing, I find it to be a very rough guess of when, like for example, it's and under the healthiest of circumstance, you don't have one bone particle in you that was present 7.5 years ago. You went through a whole recycling of all your bone. Now that's all theory. Bone has a certain time it recycles. Red blood cells recycle 3 months. You don't have, theoretically, a single red blood cell that you had 3.5 months ago. They've all been broken down and new ones have been replaced. That's a very rapid turnover there. Bone's a much slower turnover. It takes 7 years to totally replace all your bones. That's under the healthiest conditions,
Got
the
it.
most normal of conditions.
Mhm.
Well, does that health and that vitality exist? So no one's going out there and measuring that 7-year mark that I
Right.
know actively. That's not at the forefront of medical research and hormones and bones.
Well, thank
So,
you.
but it's a fun factoid. Maybe it takes you 14 years to replace every bone spicule in your body. The main thing to know is bone has an active metabolism. It's breaking down and building up all the time, and hormones play a role in that. For example, if you don't have enough estrogen, your bones break down faster. The osteoclasts is what they're known as. They're breaking that bone down faster, and that's how women lose their bones. That's the main thing. They go into menopause, they lose their estrogen, and there's a 5-year window there, and if you don't replenish that estrogen, you're going to lose a lot of bone. But progesterone plays a major role. It's the only substance on the planet that I'm aware of that stimulates the osteoblasts, the cells that lay down new bone, to lay down new bone, progesterone. So any woman who has, well, we optimize / maximize the amount of progesterone in every woman. Same with estrogen. We want to get those numbers up to where that's rich enough that she's going to protect her bones and the many other functions that are related to progesterone. Testosterone plays a role in bone, DHEA, thyroid hormone, excessive cortisol can break down bone faster. Oh, yes, it can. Acidity can break down bone faster. There's a whole chapter there. But I'm going to take us back to the 50-50. Unless someone's doing a 24-hour urine hormone test, they're playing with those ratios. And very often, they don't actually know what those ratios are producing. We always start 100% of the women on an estrogen ratio of 80% estriol. That's how much we think of estriol, 20% estradiol. We don't stay there. We will change that ratio. We'll increase the amount of estradiol, but only upon viewing the 24-hour urine hormone test. Because the 24-hour urine hormone test is going to show us in vivid technicolor, does the woman have levels of estradiol and estriol and estrone that copy nature, that have the same percentages that nature does, and is very rich in estriol for brain preservation and for health of the breasts. So I assert that if someone is adjusting those ratios, they're playing with fire. Because if you vary from 80-20 in most women, you're going to give them too much you're going to give them more estradiol than their bodies are used to. So I'd say start with 80-20 at the 3 to 5 month mark. Do a 24-hour urine hormone test and replicate nature. A lot of the times you're going to come in with nature. Some of the times you won't. Some of the times you'll see that the woman needs a little more estradiol and a little less estriol. So that's when you tweak it, but you're tweaking it according to a hormone assessment panel that
Right.
it's just wonderful. So I can't begin to say that 50-50 is right. I never started 50-50. I have gone to 50-50. I've gone to 60-40. I've gone to 70-30. I've got one woman that's a very, very unusual situation that has 20-80, 20%. But this is so rare.
Yeah.
The majority of women are going to come in at 80-20 and they're going to replicate their youthful balance. That's what we're heading for. They're the balance of estriol, estradiol, and estrone that was present in young, healthy women. Some women are going to need 70-30. Some women are going to need 60-40. Most every single woman falls within those three ratios. There are exceptions. Some go 50-50. I've seen 40-60, rarely. And that's it, with that one wild exception outlier that I told you about. So there's some thoughts about 50-50. And the idea, what do you want to do? You want to get the estrogen levels right. And you don't want to rely upon testosterone to do it. No way.
Right.
Oh, you want to get that testosterone right. You want to get that testosterone right as much as you want to get the proper amount of oxygen in the day. Not that extreme, but you want to get that right.
Close. I say close for sure.
You want to get that testosterone is dialed in as excellently as you're getting the estrogens dialed in, and the progesterone and the DHEA. And someone asked us about DHEA.
It's here. I can read it if you'd like.
Please, yes.
It says, "Good morning to both of you, precious people." I read the wrong question, but good morning. Dr. R, most PHRT specialists focus on estrogen, progesterone, and testosterone, but you also focus on DHEA. Please, can you tell us why and what role it plays?
Well, without knowing specifics, Dr. Jonathan Wright mentioned this phrase to me so long ago, and he's popularized it. He says, look, when in doubt, copy nature. Do what nature did. Don't try and redesign the human being. And DHEA, it's not as hormonally active if it's hormonally active at all. It probably does have some hormonal activity, but it also converts biochemically to testosterone and estrogen, to estrone actually. And we don't know the exact precise role it plays, other than it's so prevalent that there's more DHEA than there is the other hormones. Some call it a prohormone, some call it a hormone. And here's what I know for certain, having tested hundreds and hundreds and hundreds of women. DHEA is pretty rich in a young, healthy woman, and it declines. And there's scientific studies delineating that. It starts up here when you're 20 to 22 and declines your whole life. And it does so in men too. So it's very important in men. And by the time a woman is in perimenopause or menopause, it's low. And 95% of the women, I've tested that many women to make that's not an exact percentage, but it's close. That DHEA has really declined, along with the other hormones. And so to leave DHEA at a very low level when it's the most prevalent of these steroids doesn't make sense to me. I say copy nature, just replenish some DHEA. I don't need it up at youthful 20-year-old levels, but I don't want it to be in the gutter. So that's why I pay attention to DHEA, and we're producing a 24-hour urine hormone profile that isn't exact as to the levels of a young menstruating woman. That's not necessarily beneficial or desirable to bring back menstruation, but certainly to bring the levels up to where the bones are protected, where the brain is protected, where the arteries are protected, when the vagina is protected. Definitely want to do that with estrogen. We want to bring it into reasonable ranges. And we know what those numbers are. And we also don't want to leave out testosterone. My God, you lose testosterone, you're going to lose your muscles. Bye-bye, and you're going to lose your bladder control. And you're going to get to wear adult diapers and use a cane, walker, and wheelchair. Just from the loss of testosterone. For most women, that'll happen to them. So we want to get all these levels up to reasonableness, and we include DHEA.
You froze. Okay, so you're with me, and Dr. R will come back in just a moment. I'm really, really happy that all you guys got to see the wonderful interview with dear Dr. R and really dear Dr. Berkson. She's great. She's amazing. Really got a lot of replies to that. And so happy you're all here. Happy I'm here. For me, it's the beginning of the week. And yeah, we're frozen. We are frozen. Let me put this in the private chat. At least, yeah, Facebook user says that was a great show. It was a great show. And we're going to have a few other guests on too that are really amazing. One man, Jim Hernser, who's a compounding pharmacist, is just lovely. And we did an interview with him, geez, like a year or so ago. If I can find it, I'll put it up. But maybe Dr. R will invite him and interview him again. Dr. R is a really good interviewer. And yeah, it's cool. So yeah, good things are coming. Lots of good things are coming up. Oh my God, the Bright program and the hormones that are going to be affordable and all the stuff that Dr. R and team are working on. And again, like I'm saying, I know that, good morning, you're seeing just me because we're frozen. And I know that Dr. R is trying really hard to get back up here, and he'll do it unless it's going to be me for the rest of the 35 minutes that we have, which I hope it isn't. The last question that, yeah, we're all looking forward to the Bright program. And the minute I get the green light to put that out, I will put it out on blast. And from what I understand, geez, any doctor can do it. And Dr. R has made himself available to talk with any of these I'm sorry, I got distracted. He's making himself available to talk with any of these doctors. They don't have to be OBGYNs or what have you. They meet any doctor, and he will talk to this doctor free and explain, how to walk through the dosing and so on and so forth. Doctor to doctor, it's not that hard. It gets a little hard for us people who are sort of lay people, though we like to study. There he is. You saved me. Are you there?
We're back. I'm back.
You saved me from my monologue.
Mhm.
Okay.
So that's why we do DHEA, because nature does DHEA in great abundance, and we don't think that denying nature or avoiding what nature set up is a good idea. We think we want to copy nature, as Dr. Wright so beautifully said.
Well, nature did a pretty good job of it, didn't it? You really did. It's mesmerizing. I mean, it's really, It's interesting. Very, very interesting. Well, thank you. There again, as you always say, lots and lots of moving parts. So um, please download Happy Healthy Hormones. I'll make it available again. It is at the top of the group. I know a lot of people come sort of in the middle or whatever, but I'll make it available today. So my question number 2: do women suffer problems when they drop testosterone? I'm wondering if this could be why it is I have gained so much weight. This is the only thing that I can think of because I haven't done anything different.
Speaking of moving parts, weight gain, weight loss, there are a lot of different things to think about. We even devote a chapter in the book to weight issues, and it's not comprehensive. There are weight loss experts in the medical world that can say a lot more about it. So I'm not, we try and normalize all the hormones because they can play a role in metabolism, but I'm not going to put testosterone at the top of that list. Now, is testosterone important? Should women stop taking testosterone? It's as important as any hormone we can think of. For example, testosterone, as I've said many times, relates to the health of your muscles. So as you're in the perimenopause or the menopause, you start seeing flab develop in your triceps area, even though you're working out in the gym, you're actually losing muscle. And if you look at the lower extremities of most elderly people, their thighs have gotten real thin if they're not overweight. If they're overweight, the thighs may still be thick, but that could be thick with fat, not muscle. They have trouble getting up off the ground because they've lost so much muscle. And eventually, many older folks wind up with a cane because their muscles have gotten weak. And then a cane won't do it, and then it's a walker. And then the walker won't do it, and they got to make a transition to a wheelchair, and that's a big deal because very often many folks can't stay at home. They need too much care along with the care of their bladder, because if you lose the muscle that holds up the bladder, that's part of why women wind up with adult diapers. They lose the ability to control their urine. So testosterone is extremely important, and you want to start taking it when it starts to lower, which is definitely going to be in early menopause. Some women even lowers when they're younger. More and more these days, I see younger women in the perimenopause with already low testosterone and DHEA.
Is the bladder a muscle?
The bladder is a muscle, but it's a smooth muscle. It's not dependent like skeletal muscle, like the muscles you use to walk and stand with. Skeletal muscle is very dependent upon androgens. What did athletes do? They took steroid hormones to beef themselves up and be more muscular and stronger and hit more home runs. What steroid hormones did they take? Some variation of testosterone. Well, it screws up young men who do that because our body does not do well with excessive levels of hormones at all. So the federal government had to make it a controlled substance because people were abusing giving testosterone or testosterone-like substances to young men. And but testosterone is extremely important, so don't stop it. That's the medical advice. Start it and don't stop it. And I'm taking my testosterone every day. I'm privileged to remain on Earth. I'll probably be gripping it in my last day. having applied it already. There's quite an image.
That's hilarious. Or having had it applied.
Take your testosterone. and your estrogens and your progesterone and your DHEA. And if you need
I'll be
thyroid,
right
as
there with
many
you.
people do, take that too.
Oh, yes.
It's
Oh,
one of the
yeah.
most powerful things you can do to live long and strong.
Interesting. It's a really interesting subject. And yeah, again, one of those questions we need to expound upon. And I'm going to write down a whole bunch of them because there are things you and I still need to get to. Then it's a lot of questions and they're fabulous. And so I don't want to leave any out. This woman says, has anyone on birth control pills for years who never had melasma now is on HRT in menopause and is experiencing melasma for the first time? I also went several pregnancies without having melasma, and I'm now using the Marina coil, and it just seems to be getting worse. No one knows quite how to help me, so they sent me over to you guys at the Ins and Outs of Menopause with David Rosensweet to see if Dr. Rosensweet might have anything to say about this.
Um, you know, I delivered babies for many, many years early on in my career, and I saw plenty of melasma. And what melasma is, it's an increased pigmentation, usually on the place in our body to get the most sun, so on the cheeks and the forehead. And in pregnancy, I think it's very becoming personally. I think it makes a woman look beautiful, and it usually fades after pregnancy. It is not a disease. It's not a precursor to a disease. And that's very important to know that. Doesn't mean someone doesn't have other diseases going on or other diagnoses going on, but melasma is not an illness. It's an increased pigmentation. And what are some of the causes? Well, the rich, robust, supercharged hormone levels of pregnancy can bring it out in some women, probably those more genetically predisposed to do so. Not all women get melasma, but a lot do in pregnancy. And in a young woman who's taking a birth control pill, here she is. She's at the absolute peak of her whole lifetime of hormonal production coming out of that ovary when she's 20, plus or minus a couple of years, and you're giving her extra hormones. Well, some of these women get melasma. Now, fast forward to menopause, 28 years of specializing in treating women in menopause with compounded bioidentical hormones. I have not seen one case of melasma, but I do know it exists. And is there a hormonal component? Probably, but how would we address this? Number one, we would I would need to know so much about this patient, so we would go through our usual standard operating procedure. We would hand her what's equivalent to a 12-page questionnaire, which actually appears on an app on your phone. And we would learn so much about her, and it would give us clues about what's right and what needs investigation and what needs. I just don't have enough information about this woman. I'm assuming because she's got an IUD in there that she's perimenopausal and she's partially using the IUD for contraception. So that brings up a whole other issue in the perimenopause. What kind of contraception do you need? Best case scenario, you would start from scratch hormonally. You would remove the IUD and come up, if you need it, with some other kinds of contraception and see what happened when her hormones stabilize. If she was having regular periods, it would be useful to test her in her third week. If she's not having regular periods, it will not be helpful to test her. We'll just get confounding results. But with a thorough medical history, a procedure that every healthcare provider at the level of a physician or nurse practitioner or PA knows how to do, you start getting the clues of where to investigate this with a woman. And then you weigh risks and balances. I mean, if a woman's hormone levels are low and she's got melasma, one would want to consider giving her hormones and see what happens. Here's where I'm going to stop because I just don't know enough about it, and I'd have to be dealing with the individual patient. But melasma is not an illness. It's not a disease. So let's start there. And then it may be a much higher priority depending on how old this woman is and what phase of her, is she in premenopause? Is she in perimenopause? Is she in menopause? To deal with the hormones and see what happens. Because getting the hormones right, theoretically, would not exacerbate or amplify melasma, theoretically. But every woman's individual, and every case really needs a tremendous amount of scrutiny usually when you're trying to solve a physical body issue. So sorry to be incomplete about that, but have to bring in our friend dermatologists too to bring in their opinion about what they think about melasma. And that might be worth, maybe this person has already made a stop at their local trusted dermatologist to get their take on it.
There's something the dermatologist is saying. I tell you, amazing people. Then again, I think many doctors are all amazing people. Well, thank you very much, and thank you for answering that, and thank you for your honesty too, in saying that you weren't quite comfortable to go further. It's worth some investigation on my part. Here's one that came in, and it says, is there any truth to our having cancer cells in our uteruses and or uterus, where then taking testosterone or estrogen can make these cells grow? I do have a uterus, and this concerns me really greatly.
Wow. There's something about that question that makes me squirm. And I guess it's that I can be so literal that I thought of cancer cells being in the uterus. And I think I can make the adjustment that she's not referring to in the uterine cavity. She's referring to the uterine lining or in the uterine muscle. Well, endometrial cancer of the uterine lining can occur. Cancer of the uterine muscle is extremely rare. Talk about being in the uterus, in the uterine muscle. I'm not even aware of it, and I've certainly never seen a case. But I have seen three patients over 28 years with uterine lining cancer. Very often, it's detectable at an early stage and very curable. Yes, hysterectomy, removal of that uterus is necessary. And it's detectable because these women usually bleed in an abnormal way. And pathologists have told me, and gynecologists have told me, is that women with uterine cancer, they're spotting or bleeding in some way that you go, this is not right. And the gynecologists are just totally equipped to, when there's not right bleeding, they know how to go in there and find out what's causing it. And they have all kinds of tools to do it, starting with transvaginal ultrasound, starting with their pelvic exam, and then they can do they can look right inside the uterus, they can biopsy abnormal looking things. So it really is wonderful to have a gynecologist that you have a relationship with. And these gynecologists are trained to do these things. So barring the few not so great ones, gynecologists, for the most part, they really know what they're doing. And if there's abnormal bleeding, that's where you go. You go to your gynecologist. And I don't know how many thousands and thousands there are in the United States, but they're in every town. And God bless them. They've sure been of great support to me over the course of my medical years. And now, having said that, let's talk about cancer. Cancer is not caused by hormones. I'm pausing to let that one ring and echo. Cancer is not caused by hormones. Cancer has causes. Oh, yes, it does. To get a body to behave in that abnormal a way, there's got to have been many adversities. The way I like to think of it is, let's pretend on this wall behind me, I'm going to put up a video of a woman who's got questions about her health, a video of her whole life that a video camera person started when she was conceived in the womb, and 24/7 took video of her whole life up until the day of the consultation. And then that videographer went into their computer and pressed a magic button and eliminated all the good stuff. All the healthy habits she had, all the fun she had, all the love she had, all the peace of mind, all the good diet, all the good exercise, all the minimal exposure to toxicity, and how well she did with stress. Eliminated all the good stuff. What would be remaining would be a lot of footage. Moments in her life when something not good took place. She ate some food that had some herbicides and pesticide on it. She had some stress that she didn't do well with. She was a consistent diet that wasn't really fully up to nutrient levels. All the causes. She wasn't exercising it. All the causes that detract from our vital health. We'd see the story on that video of how she got cancer. And there's 5 causes, and 4 of them are identifiable. There's violations of good nutrition, violations of sufficient exercise and proper exercise, violations of toxic exposure and detoxification. And the elephant in the room is a dysfunctional response to the stress of life, an exaggeration of the response that's based on past buried pain. And it leads to a triggering of the fight or flight biology, and that's trouble. And it's trouble for the immune system. The immune system gets suppressed. Do that enough times, things get to grow that don't ordinarily get to grow. And so there's the story of cancer. And then there's this mysterious cause, the 5th cause, because a lot of illness is not totally explained by ordinary means. The most classic example of that is a baby who was alive for 6 weeks, seemed healthy, passed away at 6 weeks. Sometimes there's explanations that are not understandable in our current understanding of life itself, but they're there. There's always reasons. And there's a lot of stuff that can provoke a cancer. Now, I know the most about breast cancer in this regard, because that's the one that's feared most. To get endometrial cancer, people are very concerned that if you take too much estrogen, you're going to create too thick an endometrial lining in an older woman who doesn't have the immune power. Well, we don't do that. We don't. If this is, as I pictured earlier, some women are young and healthy and they have this level of hormones, and other women are young and healthy and regularly menstruating and they have this level, or anywhere in between. Treatment for menopause, for most women, not all, most, comes in below this. So we're not overstimulating the uterine lining. We're careful not to do that. We don't want to produce bleeding in most, but not all instances. And so we're not producing a thick endometrial lining, or bleeding endometrial lining, but it's not the thickness that causes the cancer. Cancer has causes. Now, will you stimulate cells? So I can say this about breast cancer. There's a physician who has some controversy, but he's written a book called Estrogen Matters. And he points out that he was one of the few oncologists who ran a running study of treating women in menopause with hormones. And what he also studied, the part of his study that was really relevant, is he was treating women who had prior history of breast cancer. with hormones. Women who have had a prior history of breast cancer have an increased incidence of recurrence than a young woman does in getting breast cancer out of the blue. But women who have had breast cancer, have had the breast cancer properly treated, have less risk of recurrence if they're treated with hormones. Dr. Blooming knows this. This is science. This is studies. And he's got one of the best ongoing studies in this regard that are out there. And even in the case of estrogen positive receptor sites, where people have expressed concern that if you give a woman who's had breast cancer who had estrogen positive receptor sites estrogen, you're going to stimulate cancer growth. But Dr. Blooming points out that those estrogen receptors were not discovered until the late 90s. And his study was he was treating with women long before, and there was no distinction between giving women with estrogen receptor sites or women without estrogen receptor site positive hormones.
I remember.
We're all the same. So cancer has causes. The causes are complex. We don't want to overstimulate a woman with excessive estrogen. That can lead to unhealthy breasts. We want to be sure that there's adequate progesterone to balance the stimulatory effects of progesterone, of estrogen. We want adequate progesterone to do that. If not, a young woman is likely to get unhealthy breasts, fibrocystic disease. These breasts are not healthy. Wherever we're not healthy, we're vulnerable. So I would say to the questioner, we're all at risk for cancer. As a male, I have special risks. I can get hundreds of cancers, but I'm at special increased relative risk for prostate cancer. And there's reasons why that's so. Well, women are an increased risk have a long list of cancers that women are susceptible to. And women are at increased risk for breast cancer and because of the endometrial cancer. But it's not the hormones that cause the cancer. There are causes. And so a woman properly treated with hormones, definitely as far as breast cancer goes, is at less risk for breast cancer than a woman.
So important for you to say.
The flip side of that is this, which very few people I find are as aware of as they are the fear that they have, the incorrect fear. They were given false information. They were scared into thinking that hormones cause cancer. That's wrong. Never was correct, even when the original 2002 study came out. But oh my goodness, I lost my train of thought there.
Well, you were talking about cancers and lots of different ways of getting cancers. The hormones being in the uterus actually causing cancer.
That what there's often a neglect is what are the consequences of not taking hormones? Oh, this list is long and problematic. Bone loss. This isn't a risk. For most women, it's a guarantee.
Yeah.
That is, they lose the hormones, they're going to lose bone, they're going to lose muscle, they're going to lose arterial protection. Young women, very rarely in their 40s, are known to have a heart attack. Whereas young men, occasionally they do. You hear he was 42 years old, he died on a tennis court, never sick a day in his life. That happens. What's the difference? Young women are protected by estrogen because if young women have a lower risk rate than young men, that risk equalizes by the age of 60. What's the difference? Hormones. This is well known. Well known. It's been known for decades and decades and decades that women have special protection to their coronary arteries. So the consequences of not having hormones are ginormous and almost guaranteed. Loss of muscle, loss of bone, loss of protection to artery, arterial sclerosis. Half the women who pass away on this planet do so because of complications of arterial sclerosis. Loss of cognition, loss of vagina, loss of bladder. That's the other thing to look at. Yeah, you think there's risks, but there's not. of taking hormones, look at the near certainty of not taking hormones. What's going to happen to you? So I think this really needs to be emphasized.
Yeah.
So, should I fear getting cancer? Well, no more or no less than the woman who's posing this question.
Correct.
Does it
Or the
serve me?
one who's asking it.
Does it
You
serve
know?
me to fear cancer? Well, what serves me is to catch myself in the moments that I can identify that fear and use the information and tools that I have to deal with fear.
There you are.
Because the fear is valid and it's rising up and it's attaching to this concept that maybe I'll get cancer. But we don't know that that's true, but what we do know is the fear has risen up in that moment. And if you don't have the information and tools to deal successfully with fear and sadness and anger and shame and guilt, I can't inspire you enough to go out and seek those tools. There are many teachers, therapists, guides who know a lot about emotions and stress. And there's wonderful tools that any of us can access and deploy. And when we pick up on, oh my God, I was sitting there this morning and I was afraid I was going to get endometrial cancer. I'm not going to tell myself something, well, I shouldn't be afraid. No, that's not helpful. I'm gonna do something like, wow, okay, let's get to the bottom of this. Let me breathe and close my eyes and feel the fear, because I've got fear rising up in me. And I breathe and I feel that fear, and I become a safe place to feel that fear. And I accept it. I allow the fear energy to be what it is. And I'm giving you a very brief introduction to one tool that can be very successful in dealing with these repressed feelings that we're loaded with. And they come up until you take on the wonderful project. One of the reasons we're on earth is to heal bundled up, repressed, uncomfortable feelings and thoughts and habit patterns that aren't life. They're misunderstandings and fears of things that we came to earth with, and we need to acquire the information and tools to do excellently with this. This is called personal growth. And there is a wealth of folks who have great understanding, have done the great work themselves. Some are professionals that guide people and share these tools and guide people into their darkest moment inside and teach them how to do it themselves. So we live in a time where this knowledge is very, very prevalent. And I urge all of you who are dealing with uncomfortable emotions and not dealing well with stress to acquire this information and tools. How do you begin? Develop the desire. Contact your desire in your heart that it matters to you to heal your emotions in your mind and your life. Pray. Ask for this support. You build the space, it will come.
It will come.
All righty.
We are close to those last 5 words.
Final question, because I have a hard stop on the hour.
Yeah, I don't even have a final question that you'll be able to answer, because I know where we're gonna go. And I'll write to you in the interim. I do have 2 that I will start off with next week.
Well, you can go for one. Let's see what I can accomplish.
Okay.
Form.
Does Dr. Rosensweet have insight into sex hormone binding globulin? Mine is way above the normal range, and it's scary to me, and I truly do not know what to do about this or how to bring it down. Thank you.
Yes. Next question.
Okay.
I do have that. Sex hormone binding globulin issues are not a disease.
Right.
You really want to know that. And sex hormone binding globulin is a globulin. It's a protein that's floating around in our blood. And it's a special protein. It has a function And that is because steroid hormones are fat soluble. They can't just float around as like fat globules in the blood. So the body has invented this carrier, this transporter, and sex hormone binding globulins is one of the large proteins that binds up the sex hormones when they come out of the ovary, for example, and transports them all around the body and lets go of them at the various organs. So it's a transport system. And in a young woman, she has a certain amount of sex hormone binding globulin that's absolutely normal and needed to transport her ovarian hormones around to every cell, tissue, and organ in her body. But should, for example, she get extra hormone, well, the body's, and where does the extra hormone come from? Birth control pills is the most common one. She's getting extra estrogen, for example. So she's at the peak of her estrogen output in her life. She's given extra estrogen. The body goes, wait a minute, that's too much. We don't want extra hormones. These are very powerful floating around. Well, one protection mechanism we can do is we can increase the production of sex hormone binding globulin, bind up the extra estrogen, and that's how the body responds to many young women. Well, it turns out that a woman's testosterone binds even stronger to the extra sex hormone binding globulin. So many of these women bind up their testosterone too much of it, and they lose their libido. This is not a disease. In most women, when you stop the birth control pill, the sex hormone binding globulin returns to normal, but not all. And that's the thing. We see women in menopause who have elevated sex hormone binding globulin, and the only way they got there was they took the birth control pill and it never went down, even though they stopped the birth control pill. I mean, that's a common thing.
Could
And
that
very
have
often,
been years and years ago?
it can be decades ago. Went up, never came down, even though the pill was stopped.
Wow.
Now, we don't hold that as an automatic problem. We care enough about sex hormone binding globulin that in the menopause method, in the BRIGHT method, we check every single woman at the beginning of treatment. We do a blood test to assess her sex hormone binding globulin level. And but we don't, even if it's a little elevated, which is common, we don't make a fuss about it. We just work with it and do hormones, and usually it doesn't present a problem. Sometimes it can get high enough where it is a problem. We got to bring it down. And the only effective thing I found to date to bring it down is a pharmaceutical medication used in endometriosis called danazol. The doses in endometriosis are quite robust. The dosages we use to bring down sex hormone binding globulin in women and in men are quite low relatively. And sometimes it takes the women taking the danazol to bring down that sex hormone binding globulin. And with that,
You did it.
This week and bid you all a wonderful week. And Carolyn, thanks again. Really appreciate
Dr. R, thank you too so much. Always fun, always pleasant, always a pleasure, and we get great information, and we all thank you so much for it. So yes, you too have a great week. And to everybody who's up here, have a great week. We'll get to your questions and enjoy.
And we'll see you next Tuesday.
That we will indeed, next Tuesday.
All righty, everybody. Bye-bye.